Bismillahirrahmanirrahim. Today's lecture is about Wolff Parkinson White Syndrome. He is Sir Louis Wolff, born on April 14, 1888 and died January 29, 1972. And he is Sir Paul White, born on 1888 and 1973. And in the center is John Parkinson. They discovered the disease Wolff Parkinson Syndrome, and that's why the disease is now run with the name of these three great cardiologists. Wolff Parkinson White Syndrome. Wolff Parkinson White Syndrome is a congenital abnormality which is due to the presence of abnormal electrical conductive circuit between the atria and ventricle. There is an abnormal conductive circuit between the atria and the ventricle. The disorder include accessory electrical pathway that bypass the AV node. As we know that in heart conductive system there is SA node, AV node, bundle of His, and right left bundle branch block and Purkinje fibers. In normal condition, impulses are generated in SA node. They pass through the conductive pathway to the AV node and then to the ventricle. But in Wolff Parkinson syndrome, there is an accessory pathway which directly communicates from the atria with the ventricle. The right atria is connected directly with the left ventricle, and the left atria is directly connected with the left ventricle, right with the right and left with the left. And this connection is maybe thin enough like the hair of human being. And through these pathway, current are directly passed from the atria to the ventricle and cause excitation of the ventricle. As we know that when the current is normally passed from the SA node, there is a delay in the AV node. But in this direct pathway, there is no delay and the current is directly passed to the ventricle. Prevalence of Wolff Parkinson White Syndrome. Wolff Parkinson White Syndrome can occur at any age and affect approximately 1 to 3 per 1,000 patients. A small percentage of these patients may have a genetic mutation. In patients who have familial Wolff Parkinson White Syndrome, the patient will have inherited the condition from affected parents. Sign and symptom of Wolff Parkinson Syndrome. With Wolff Parkinson White Syndrome may present with the following sign or symptom: rapid heart rate, palpitation, shortness of breath, fluttering, feeling in throat, low blood pressure, dizziness, syncope, or cardiac arrest, which is rare in this condition. Conductive system of the heart. In order to bring the electrical impulse to all parts of the heart in a uniform fashion, the heart has a specialized electrical pathway known as the conductive system. A normal heartbeat is produced by the heart natural pacemaker. The sinoatrial or sinus node send out a series of regular electrical impulses. These impulses travel in an organized way along conductive tissue in the heart, passing first across both atria, then to an area between the atria and ventricle known as the atrioventricular node, and finally spreading across the ventricle, which are the heart's main pumping chambers. Here you can see the normal conductive system of the heart. This is the SA node conductive pathway. The current spread on both atria and then reach the SA node, and from SA node pass through the bundle of His, right bundle branch, and spread over the both ventricle and cause them to contract, which are the main contracting chamber of the heart. The normal heart rate is generally around 60 to 100 beats per minute. Causes of Wolff Parkinson White Syndrome. Normally, the only electrical conduction between the atria and the ventricle is at the AV node. When impulses are generated at the SA node, they are passed through the AV node to the ventricle. This is the only pathway in normal condition during which the electrical current is passed from the atria to the ventricle. Conduction in the AV node is slower than in other part of the conductive system to allow time after atria contract for the ventricle to fill with blood before conduction. Here a delay occurs and it provides time for the ventricle to fill up with blood. People with Wolff Parkinson Syndrome have an extra electrical pathway between the atria and the ventricle known as accessory pathway. You can see that from SA node a direct pathway which bypass the AV node and enter the ventricle, and also there is a pacemaker or leak in the insulating system of the atria, and this pathway passes from the SA node directly to the left ventricle. This abnormal pathway directly connects the atria and ventricle at a side other than the AV node. These are different sides by which this current passes from the SA node to the ventricle and connect the ventricles. It can be considered a small gap in the insulation between the atria and ventricle. An accessory pathway allows the electrical signal to travel from the atria to the ventricle more quickly than normal, bypassing the AV node where the electrical signal travel more slowly. As a result, the normal sinus impulse can travel down the normal pathway through the AV node as well as the more rapidly conducting accessory pathway. So there are two pathways, one is the normal pathway and the other is the accessory pathway. Here in the normal pathway block occur, but in accessory pathway the impulses are directly and fastly passed from the atria to the ventricle. This allows the impulses traveling through the accessory pathway to reach the ventricle earlier, causing pre-excitation. The presence of two pathways, the normal one and the accessory one between the atria and the ventricles, poses a risk of developing a short circuit of the normal electrical pathway, with each can result in an abnormally fast heart rate, also called tachycardia. Fast heart rate is called tachycardia. People who have recurring tachycardia because of this abnormal pathway are said to have the Wolff Parkinson White Syndrome. These people are said to have a Wolff Parkinson White pattern which can be detected on routine electrocardiogram, also called ECG. Wolff Parkinson White Syndrome diagnosis. Electrocardiogram, this can be diagnosed during routine electrocardiography for other causes. Conduction through the accessory pathway produce a characteristic ECG pattern. A classic finding is a short PR interval. This is PR interval, so this interval is become short and it is less than 120 millisecond between atria and ventricle, and a delta wave with reflects early conduction pre-excitation to the ventricle through the accessory pathway. In there, this is a P wave, and another wave is produced by the accessory pathway which is called a delta wave. So this is present in ECG when a person is suffering from WPW. Here I will how the delta wave is produced in the ECG. we have two chambers, the atria, right and left atria, and right and left ventricle. Here is the SA node and this is the AV node. From SA node, impulses are passed to the AV node and left atrium through Bachmann bundle, and then these impulses from both atria pass through the AV node to the ventricle bundle of S, left bundle branch and right bundle branch. In Wolff Parkinson Syndrome, there is accessory pathway, and these impulses directly pass from atria to ventricle. Here you can see that these impulses are passing directly from atria to ventricle and cause excitation of the ventricle. In normal case, this ECG is produced, ECG graph is produced. There is a P wave, Q wave, R, S and T wave. But in Wolff Parkinson Syndrome, when the impulse passes from the atria through the SA node to the ventricle, the P wave is produced, but at the same time the impulse through accessory pathway is also passed to the ventricle and excite the ventricle ahead the atria, and this produces a wave which is called delta wave, and then the RS complex, ST complex. So this is a delta wave which is produced during Wolff Parkinson Syndrome due to the impulses pass on the accessory pathway from atria to the ventricle. Wolff Parkinson White Syndrome treatment. When the tachycardia is an atrioventricular re-entrant tachycardia. When the tachycardia is an atrioventricular re-entering tachycardia, which is also called AVRT, can often be stopped by interfering with the circular loop. This can be achieved by simple maneuvers, massaging the main artery in the person's neck, called carotid sinus pressure. When pressure is applied at this area, this is called carotid sinus pressure. When this area massage is done in this area per 10 to 20 seconds, the rhythm can be bring back to the normal rhythm. Another mechanism is by modified Valsalva maneuver, in which the patient is laid on supine on a table, his legs are raised high, and a syringe removing the needle is given to him, and he is asked to blow air into the syringe. This maneuver also brings the heart to normal rhythm, and this is called modified Valsalva maneuver. Stopping the tachycardia. The best medication depend upon the mechanism that is responsible. In most cases, the person must go to an emergency department to receive intravenous medication to stop the abnormal rhythm. Cardiologists with experiencing in the treatment of rhythm disturbances often assist with treatment in this case. Stopping the tachycardia. If a person is unstable due to low blood pressure because of rapid heart rate, or if the medication is not immediately effective, electrical cardioversion can be used to stop the arrhythmias. There are three major options for preventing recurrence of tachycardia: radio frequency ablation, medication and surgery. The choice is best made with a heart rhythm specialist, cardiologist who has experience in treating the Wolff Parkinson Syndrome. Radiofrequency ablation procedure are performed in a hospital electrophysiology lab using X-ray equipment and can take 2 to 3 hours to complete. Electrode catheter is advanced into the heart from large blood vessel and positioned within the chamber of the heart using fluoroscopy, low energy X-ray. After the accessory pathway is localized, radio frequency energy, high frequency electricity is delivered to the area of to destroy or ablate the accessory pathway, preventing it from conducting impulses. Surgery is another method to disconnect the WPW pathway. The success rate for surgical ablation is close to 100% and the complication rate is low. However, radiofrequency ablation is a less invasive option. As a result, surgery is now rarely performed. Surgical ablation may be preferred if the person is undergoing reasons such as coronary artery bypass surgery or wall surgery, such as coronary artery bypass surgery or wall surgery, when radiofrequency ablation and medication are not effective. Medication for WPW. Medication are usually used in people who are not candidate for ablation or surgery. These people may give medication to use during an episode or to take daily to prevent the arrhythmia. They may also be thought to perform maneuvers, e.g. Valsalva, that can stop the tachycardia. The pharmacologic treatment of choice for antidromic AVRT is procainamide. Procainamide and ibutyllide are agent of choice in atrial fibrillation with pre-excitation on ECG. Amiodarone has been used in Wolff Parkinson Syndrome pattern with atrial fibrillation, but some evidence suggests that it is less effective and has higher risk of precipitating ventricular fibrillation. AB node blocker should be avoided in atrial fibrillation and atrial flutter with WPW or history of it. This includes adenosine, deltazim, verapamil, and other calcium channel blocker and beta blocker. If AV blocker are induced, there is high rate of impulse production in the ventricle, but there is delay at the AV level. If the AV blocker are given to the patient, this delay in the AV node is also stopped, and both the impulses through the accessory and the AV node are entered into the ventricle at the same time and cause ventricular flutter. They can exacerbate the syndrome by blocking the heart normal electrical pathway before atrial to ventricle conduction through the pre-exciting pathway, potentially leading to unstable ventricular fibrillation. So thank you. Please subscribe the channel and press the bell icon for updating.